video on chest tube insertion. And this is my cat, Glunkus, because he is large and ginormous. We're not going to do a chest tube on Glunkus, but he keeps meowing. So if you hear anything in the background, that's Glunkus. Say hi. Okay. So, to follow along, I do have this in your modules. It's called chest tube setup. That's the first thing we're going to go over. And then we're going to go over slides 40 through 44 in your PowerPoint that are chest tube monitoring. So we're going to be going over how we're going to set up the chest tube. And guess who I brought home? It's Carl. Welcome, Carl. So Carl's going to be here to help us with this demo so I can show you how to do a chest tube dressing. The first thing I'm going to show you, and I want to say thank you to Matthew in the back here, who's my videographer. And she's going to be Cat Patrol too. All right, so this is a chest tube. This is a chest tube. They come in containers like this. This is what you're going to hand off to the doctor when they ask for the physical chest tube. There's also a chest tube insertion tray, which I don't have a picture of. And that is going to be what they're going to use, has all the surgical equipment that they're going to need to get this into Carl here. So we're going to bypass the actual procedure, but I'm going to show you that you're going to need a chest tube catheter. And I'm actually going to have this chest tube catheter put into Carl completely unsterilely, but in real life, the doctor would be putting this in at the bedside, and your job is to have the chest tube drainage container ready to go. So these are two different sizes. This, I don't know if you can zoom in there and see right there. This is a 28 French, which is, this is actually the 28 French. It came out of the container. This is a 28 French. On the end there, it tells you the size of the catheter. And this is actually a 24 French. So you would have to match the correct, so this one technically should be in the container. But this is a 28 French to 24 French. If you can see the difference there, the 28 French is much thicker than the 24 French. So, in case they ask you, that's what the French sizes are. So we're going to put that aside for right now, and we're going to say that the doctor went ahead and put this in. He's getting ready to put that in at the bedside. Your job is going to be to get the drainage containers ready to go. There are two kinds. When you get them, they will be wrapped in sterile wrapping with everything wound up on the inside. This is what we call a wet chest tube drain, and it has the name Ocean at the top because it is wet, and I will explain what that means. I'm going to put that one right here by Carl's feet. And we have a dry chest tube drain, which also comes with everything that has on the wet one, but it has a little bit of a different setup. So we're going to talk about the two different ones and why we're going to pick one over the other. It is your choice. What we are going to be interested in, over here, please, Matthew, thank you, is when we're looking at these, we're looking at the amount of suction that they can give. The physician is going to order a chest tube amount. They're going to order, and keep it focused on the chest tube things, he's going to order a certain amount of chest tube suction. The suction that's on the wall is going to be coming out at the regulator, but we don't trust the regulator on the wall to suction it. We're going to suction it at a certain ordered percent. The doctor will order the amount of suction. On this one, you can see the amount of suctions is 10, 20, 30, and 40. On this one, the amount of suction is found here on the wet side. So we have to put water in to get the right amount of suction. On this one, we can turn, there's a dial on the side. We can turn the dial on the side to the correct amount of suction. So let's say this chest tube, this doctor ordered 20 centimeters of suction. We would turn it there, easy peasy, first step done. This one's a little bit harder. You have to order 20 of suction. The only way you can get 20 centimeters of suction is by putting water in the container. Where did my water go? There it is. Can you get good close-ups of the actual chest tubes? Okay. So what I'm going to do here is, this is distilled water. For reals and for trues, this is distilled water. It goes into, there's a little pop-off area here. You're going to pour your sterile distilled water into the chest tube container until it reaches the 20 centimeter mark. So I don't know if you can see the water rising there, but I am pouring this in, and it is slowly getting up to the 20 centimeter mark. There's actually dye in these. If we haven't been reusing these over and over again, and it would be blue. So we're going to turn that to 20. We poured 20 centimeters of water in there, and that is now, when we turn this on to suction, going to be 20 centimeters of suction. If the physician ordered 30 or 40 centimeters of suction, how would you do that on here? You wouldn't. These don't go past 20 centimeters of suction. So if your doctor's going to want 30 or 40 centimeters of suction, you need to pick the dry container that has a dial of flow on it. So you have to pick this one if you want more than 20 centimeters of suction. This one will do 5, 10, 15, or 20 centimeters of suction, but that's it. So part of our choice is determined on what the physician's going to order. So you can ask them while they're getting ready to do this, what section are you going to want on your patient? The more air or blood or fluid that's in the chest is a higher amount of suction. The doctor will tell you what they're going to order. So once you have this set up, the second part, these are already set up, but the second part is to now get your air leak. This is the air leak detector and the water seal chamber. So the first chamber on all of these, the A chamber, is the suction control chamber. Second chamber is your water seal chamber here and your air leak detector. So B is labeled for the water seal, and every single chest tube has a water seal. You don't have to have suction, but you do have to have a water seal. And the reason you have to have a water seal is if we don't have a water seal, whenever they take a breath in, air could get in from this container into their lungs. So we definitely want air allowed out, but not back in. So when we take a big deep breath in, water can't get through this seal and get into the tube and get into your chest. So every single chest tube needs a water seal chamber filled to this 2 centimeter mark. So you can see the marks labeled here. This one's a little bit on the low side, and so I'm going to go ahead and fill this one all the way up. On the back of this one is like a little sterile container there that we can put this in, and you can see it's filling up this container here. It is just enough fluid to fill that whole container. So I am filling up that container. So we have 2 centimeters of water here, 2 centimeters of water here. We have 20 centimeters of suction, 20 centimeters of suction. So right now, both of these can do the same thing. The third chamber here is for drainage from the chest. So whether if you're draining air out of the chest, you're probably not going to have very much drainage in here. But if you're draining blood out of the chest, or pus out of the chest, or fluid out of the chest, you may have a little bit of drainage. The drainage is going to depend on what's in your chest. So the next piece is to actually hook this up to the patient once the doctor has the chest tube in. Doesn't have the chest tube in yet, so we are going to work on getting this hooked up to the wall suction. So the wall suction, I don't know if I don't have a wall suction here because we're home now, but this is going to take the place of my wall suction. This is a little suction meter thing. So this is going to be my suction from the wall. We need a suction container here, and you need two suction tubings. You need 1 suction tubing. You need 2 of these coming out of sterile containers. These are sterile, of course. This is going to be on your wall. You're going to hook one of these from the wall. So we're going to hook that to the wall, suction there, the wall to this container, and it will say vacuum. And then this one is going to go to the patient. So we're going to hook our second suction up to the patient container. This will go on our wall. So I'm going to put this on our wall back here. So from the wall to the canister, and from the canister to the patient. Now we could, if we wanted to, hook this straight to the chest tube. But then what we're going to do is we're not regulating the pressure. You can't really get a pressure of 10 or 20 centimeters of water on the wall suction. It just doesn't work. So we're going to kind of reduce the suction out. So it doesn't matter what's coming out of the wall. You can put your wall suction to 80, 100, whatever you want. This suction canister, or the suction catheter here, is going to go to either here on the wet suction or to here on the dry suction. So there is a place for the suction. It's always right above the water seal chamber. Okay, so let's hook it up to this one first. And I'm going to show you what they're going to do, and then we're going to put the chest tube in, and then I'm going to show you what to monitor. So I'm going to take the end of this tubing and use my pretend suction here, and you can keep an eye on the suction chambers here. So this is my suctions being turned on, and I'm hooking this up to suction. So now that this is hooked up to suction, you're going to be watching the suction chamber, and I'm going to show you what happens here. Look what is happening to these chambers. I have suction now to my canisters here. It is bubbling in the air leak chamber. It's bubbling in the air leak chamber because air is coming in from this tube to the chamber. It is sucking air from the air into this chamber. If I close off this entry hole here, what happens to the suction? Hopefully. Oh, technical errors. Now where is the suction? The suction is bubbling in the suction control chamber. This is what we're going to see when we hook. This is going to get hooked up to our patient, okay? Our chest is a closed system. There's no air in our chest other than what is coming out into this drain. So this simulates putting it on the patient. I am closing that hole. When I open it, air leak, because there's a leak of air. When I do not have an air leak, let it pull that air in. When I do not have an air leak, then there is no bubbling in here, and all the bubbling is in your suction chamber. Okay? So that's what it should look like hooked up to a patient. All right? So when you're looking at a chest tube, you should see bubbling in the suction control chamber, no bubbling in the air leak chamber. Okay? If you do have an air leak, you do have air in your chest, then it will pull that air out of the chest. So I'm going to simulate an air leak in the chest now. And now you see you have a little bit of air leak. I have a little bit of air that's pulling from the atmosphere into this chest tube. So an air leak is going to be intermittent only when you take a breath. Okay? A continuous air leak means something has become disconnected. So when you're looking at this chest tube, this is not normal. That is not good. Something has become disconnected and you need to check. This is normal. So if you're looking at these two canisters here, we'll let it suck all the air out. That is normal. Bubbling in the suction chamber, no bubbling in the air leak chamber. The only time it is normal to see bubbling in this air leak chamber is if you had a pneumothorax and we are pulling the air out of the chest. That's the only time it is okay to see bubbling in that chamber. Otherwise, you should only see bubbling here, no bubbling here. An intermittent air leak is okay only if you have a pneumothorax. This is what we should be seeing. If you see this at the beginning of your shift and then you start seeing bubbling in here intermittently, that's an air leak from the patient. Constantly is an air leak from a loose connection. Okay? So that is the wet container. That is what you're supposed to see. And drainage is just drainage. We're going to measure the drainage. So now we are going to hook up our suction to the dry container. And I'm going to show you what we're going to see. So we're going to hook this up to the dry container. We're still at 20 centimeters of suction. And now we're seeing bubbling in the air leak chamber, continuous bubbling, because we have a leak in the system. Okay, so we're going to close the leak in the system and watch right here. As we close this system, now normally when you stop doing air, is this working? Is it not working? Okay, pause for a minute. Show you is there should be no bubbling in there unless we have an air leak. And you are looking here. So here we saw bubbling if our suction was working. Here, we're going to look at this indicator to see if our suction is working. I'm going to take it off suction for a minute. Did you see the orange thing go away? And when I put it back on suction, orange thing comes back. So that is our indicator that our suction is working, is this orange thing on the back. So when I take this suction off, no indicator. When I put the suction on, indicator. So we know our suction is set at this correct amount if this indicator is out, and we are going to watch this for an air leak. This patient, whatever patient I'm making up here, has an intermittent air leak. Do you see how it's just every now and then? That is called an intermittent air leak, and that is what you will see for pneumothorax. Okay. If there is a leak in the system, or this is open to air, it will be continuous bubbling in that system, and we don't want continuous bubbling. So, trying to get a ton of air into the system here. Oh, I'm holding up the wrong one. Lord have mercy. Okay, so if I blow, so the other thing I'm going to show you, so I've shown you suction. I've shown you this is an intermittent air leak. Let me close off my air leaks here. My cat is getting bored and is getting ready to leave. All right, so the other thing I'm going to show you is something called titling, which is normal, okay? When these tidal, what you're going to see is when I blow into this chest, or we take a breath. Let me move this one out of the way. This one's going to this chest tube. I have too many chest tubes. This one's going to this chest tube. So when this is hooked up to your chest, when you take a breath in, it's not working. It's not working because it's clamped. We're going to talk about never clamping a chest tube. Continuous air leak. Leak in the system. No air leak. System is closed. So let's close our system. But we are going to take a breath. I want you to watch over here, this channel right here that goes up to 0, 1, 2, 5. Every time I take a breath in, this goes up because the pressure in my chest is going up as my lungs fill, and then it will go down as you exhale. Titling is normal. You will see titling in here as well. So those are kind of the basics to chest tubes. When you're looking at your chest tube setup list here, perform hand hygiene, of course. Open the drain packaging, which was already done. They were over here on the bed. Prepare the drain as instructions, which is wet suction. Add sterile water to the 2 centimeter mark, which we did here. Add water to the 20 centimeter mark, or as ordered in the suction control chamber. That was over here. For the dry suction, you just add sterile water to the 2 centimeter mark, which was here. Pass the sterile. So we set these all up, and they are basically ready to go. So I showed you the chambers, and they are ready to go. This is the end that comes on the ends of these tubes. There is a sterile cap on the ends of these tubes, okay? We leave that sterile cap on until we give it to the physician. Right, so you can get these set up ahead of time, and even to suction ahead of time, and just leave the sterile cap on the end to go to the physician. Same thing if you set up this one, you would just leave its sterile cap on at the very end. This sterile cap would stay on until you hand it to the physician. All right, so we have our sterile cap on, and we are ready to put this chest tube in. The physician is going to put the chest tube in, and then we'll talk about how we're going to maintain it. I'm going to turn that off for a minute. All right, so the chest tube's going to go in because Carl's going to put his hand up in the air. The surgeon's going to come in here at the level that he wants to go in. They put him in low for fluid drainage, something like blood or fluid, and they'll put him up high for air drainage. But what they're going to do is they're going to go in there with our tools, and they're going to put this chest tube in. And then they're going to ask you for the suction chamber. They're going to ask you for the drainage. They're going to hook this up and watch for drainage to come out. So what you're going to do is you're going to hand them the tube that you have kept sterilely. They're still going to be sterile. You can take this top off and hand that to them sterilely, and then they will connect it. And that's usually how they leave it. They will leave it like that, and then it's our job to get it, to make sure it's all set up at the correct suction, which we already did prior to them putting it in, and we're all ready to go. So we have our 20 centimeters of suction ready to go, and we have this hooked up. When you do that, whatever is in this chest is going to come out into the drainage container. We do not leave them up at the bed. We leave them on the floor, but for demo purposes, I'm leaving them here right now. The dressing on this is going to be, we want this to not get air leak around it, right? So once this comes out, we're going to use, this is Vaseline soaked gauze, sterile Vaseline soaked gauze. I'm going to have my sterile gloves on, pull the Vaseline soaked gauze out sterilely, and I'm going to wrap that gauze around the tube so that no air can get into this chest here. And then we're going to cover it up with my very sterile covering. And we usually will tape these down the chest so that they're not uncomfortable and they're not pulling on the patient. And so we have sterile gauze on there, we have our dressing on there, and then we will tape this. So this is not going to be a beautiful picture on here. But we're going to tape that on. And you will have an occlusive dressing here. And you're going to put tape all over the side here. Now, this will still be able to come out. The surgeon may suture this into place, but it's our job to get a nice, clean, sterile dressing on there so that nothing can get into that hole into the chest, all right? Sterile Vaseline soaked gauze around it, and then a nice dressing on there. To make sure that these do not come out, we'll then probably tape it 1 or 2 more times down there. We also don't want this to tug. These patients can get up with chest tubes in, but if there's any tug, we want it to be tugging down here, not at the insertion site. So we want to make sure that this dressing is well taped and that this is taped down. We also don't want anything coming apart here, because that would be bad. They would be able to just suck air straight into their chest if this came apart. There's no water seal. There's nothing to seal air from getting in there. So we have to maintain this together. You'll see people will put cable ties on these, or we will tape them. But we need to secure all the connections so that they cannot come apart, okay? If they come apart, you could end up with a pneumothorax if you didn't have one before, or a larger pneumothorax if you didn't have one before. So tape all your connections all the way. Make sure all your connections are tight. And then when you hook this up to the wall, I put him to the wet chest tube. So we are going to hook up the suction to the wet chest tube. And the important thing when you're hooking up to these drainage canisters is you don't have to have the suction on right away, but you do have to have water seal on right away. If we hooked this up to the chest tube drainage system, so it's all the way from the patient to the drainage system, but there was no water seal in there, as soon as they took a breath, air would go into their chest cavity. So you have to have the water seal done. That is a very minimum to hook these containers up, is the water seal. But since we got the suction put up, we're going to go ahead and hook it back up to the wall. We had it all set up right, but I took it all apart so I can show you the different chest tubes. And Carl does not have an air leak. He does not have a pneumothorax. So, thank you, Carl, for not having a pneumothorax. As soon as I get him, this is what we're going to see. Carl does not have a pneumothorax. Let's say we're draining some blood out of Carl's chest. We're going to see bubbling in the suction chamber, normal. No bubbling in the water seal chamber, normal. And we would see titling. If Carl was breathing, we would see this rising and falling, normal. We would see drainage coming into the marked containers. That is what a normal chest tube setup looks like. That's what you should be checking at the beginning of each shift. You should be checking your suction to make sure that it is bubbling or set at the correct amount. You will make sure that you have water in your water seal chamber and that there is no air leak. If Carl did have a pneumothorax and we were trying to drain air out of his chest, then we would want to see this. So we would want to see suction, and I'm going to try and give him a little air leak. Do you see how every time he takes a breath we have air? So I'm simulating him breathing. That is what a pneumothorax looks like. That is a normal finding for a pneumothorax. So bubbling in the suction control chamber and intermittent bubbling in the water seal chamber. That is air escaping his chest every time he takes a breath. We want that. We want air coming out of the chest. We just don't want air going back into the chest. Let's say Carl became disconnected here. We didn't do a good job of taping him. Oh, I did a too good a job of taping him. Let's say I didn't do a good job of taping him. Wow, I did a really good job of taping him. It's almost like I do that all the time. All right, let's say this became disconnected. Lord have mercy. Oh, no moment strength. This became disconnected. Now what do we see? No bubbling in the suction control chamber and constant bubbling in the air leak chamber. That's because this became disconnected. As soon as we get him reconnected, but while this is bubbling and empty, guess what he's breathing in over here? Air. And his pneumothorax could be getting worse. It is a priority to get this thing hooked back up so that you can pull out whatever air that did get into him while this was disconnected. Okay. So we really want to make sure, and that's where I'm going to go over all these different things. So remember, bubbling or toggle out on the suction control chamber, water leak chamber, suction control chamber either has this out or bubbling. Water seal chamber has no bubbling or intermittent bubbling only. And then you should have titling up and down with each breath. And then drainage. Okay, so those are what we're looking for. And I will just go over real quick during class tomorrow. So we're going to observe the water seal chamber, all the things I just told you. We expect water filled, titling. We expect intermittent air bubbling if they have a pneumothorax or no air bubbling. We never expect constant air bubbling. That means you have a leak in your system and you need to investigate your picture. You observe the suction chamber. You expect bubbling or the toggle out, and that is normal finding. We do not expect that the suction is set at the wrong amount or that the suction is low. What happens in Arizona with these is that it evaporates. And so you think you have 20 centimeters of suction. You think it's ordered. It's bubbling, but then if you shut off the bubbling, it drops down to 15 or 10 because it's evaporated, and we got to make sure that the water stays to the correct amount of suction. So you want to make sure that your suction is at the correct amount, so you're either going to check there or check your water level on there. And then we're going to observe the drainage collection to mark our drainage. Usually, because we don't change this out until it's full, we will mark drainage and the time next to it, so we can count how much drainage we had for the shift. We are observing everything from the patient to the collection chamber, making sure that everything is tight and sealed. Let's say, for one last emergency, you come in and find that Carl has gotten up out of bed and this whole thing has come out. Oh no. What do we do? He's got a giant hole in his chest. What are we going to do? Emergency care of a chest drain that has come out is cover it to the best of your ability with something sterile until someone can get an occlusive dressing. And what an occlusive dressing is going to be something that is plastic, probably a tegaderm over a gauze, something that is occlusive. But we want to put a dressing on. So let me find, I thought I had a tegaderm out. But what we are going to do is put, let's just say this is an occlusive dressing. Occlusive means no air can get through it. We're going to put our occlusive dressing on, but you're not going to seal it all the way around. Okay, so let's say this is a piece of dressing, and it's probably something with Vaseline, something that air can't get through. You're going to put the dressing on, but you're only going to put it on 3 sides. Because what's going to happen is when they exhale, air will go out, but when they inhale, it will suck up against that hole and keep air from entering the chest on an inhale. And then when they exhale, it will open, and when they inhale, it will close off. So an occlusive dressing, there's a good picture on your slideshow of an occlusive dressing, but it is a 3-sided dressing. Make sure to leave one side open so that when they exhale, air can come out, but then when they inhale, it gets sucked up against there and doesn't let air into the chest. So a 3-sided dressing is your emergency treatment of a chest tube coming out, and then an emergency chest ray and a call to the doctor so they can get it put back in. And I think that is all I have to say about chest tubes. Thank you.